All right, so welcome everyone to our October lunchtime presentation. We are having these monthly events celebrating our 100 years at Scripps. And I'm happy to say that our event last week was awesome. We had great attendance, a couple hundred people came to different events, and just was a really great celebration together. So thank you to those who could be there either virtually or in person. So today we are going to talk to alumna Marisa Scala-Foley. She's an MGS grad from 1995, finding pathways forward, the evolution of a career and of the aging network. Marisa now serves as the director of aging and disability, the director at the Aging and Disability Business Institute at US Aging. Marisa has had a career in the field of aging on issues related to healthcare and long-term services and supports, and we look forward to learning more from you today. So welcome, Marisa. I'm going to go ahead and let's see, spotlight you. There we go. And take it away, Marisa.
All right. Thank you so much. Sorry, I saw the little spotlight on the Zoom thing and I thought, okay, am I muted? Because I usually do that at least once once a Zoom meeting. Someone has to remind me to take myself off of mute, but I'm guessing you can hear me. So we will go ahead and get started. It is really great to be here with you all today, to see a lot of familiar faces on the screen, which is really wonderful. And I am thrilled. I am honored by the invitation and thrilled to be here with you all today to have this conversation. I was saying on my call just now with the Indiana AAAs that it's exciting and a little bit intimidating to feel like to be asked to talk about anything you want, pretty much related to your career and what you're working on and so forth. But it was a lot of fun for me to think through sort of what the privilege that I've had to work on so many exciting things, and the policy changes that I've seen in my career, which has spanned longer than I like to think about at this point, and sort of where things are going when it comes to the aging network, because I've been lucky enough to kind of be in a maybe not in a front row seat, but somewhere in the front part of the theater, kind of watching the aging network and area agencies in particular grow and change over the course of my career. So it's kind of fun to talk about that today. So let me kick things off and get started. So you can see here on the screen, and as Leah pointed out, I got my MGS degree in 1995, and I talked about several years ago, I was fortunate enough to be given the Cottrell Award and got to come out and talk with students and faculty and so forth. And one of the things that I said was, Scripps is really where I learned to be a professional. While my interest in aging was kindled, sort of when I was in college, and even before that in some volunteer work I had done in a nursing home, Scripps is really where I got to see upfront professionals who were, interested and engaged and passionate about the work, and kind of decided that, I wanted to kind of be them when I grew up. So I don't know that I've achieved that necessarily, but I have gotten to, it really sparked in me my interest in the field and in working with the tremendously dedicated professionals who inhabit the field of aging, and to watch the field grow so much over the course of the past now almost 30 years since I got my MGS degree. So it's really been exciting to watch. But so a little bit about what my career trajectory has looked at, because I've gotten to experience the field of aging and gerontology, and I am one of the few people whom I graduated college with who actually is working in the field that they got their degree in. Because I have in addition to my MGS, I have a bachelor's in sociology and a certificate in gerontology from college. And I have been in the field of aging my entire career. I don't anticipate ever leaving because I really do love the work, love the people I get to work with. It's been really incredible to watch. So after I got my MGS degree, I spent some time working at Scripps. Actually, Suzanne, who I know is on the phone today, kind of came to me when I was graduating, when I was trying to figure out where I was going to go and what I was going to do, and said, "Hey, I know you want to move back east," which is ultimately where I landed. I live I live in Alexandria, Virginia. I work in Washington, D.C. right now. She said, I know you want to move back east, but we have this research position open. Would you stay for just a year? And I couldn't say no, because it was a really exciting opportunity to work on the Ohio Long-Term Care Research Project then. And 1 year turned into 2, turned into 5. And I still, and Bob is probably chuckling, because when I was an MGSer, I wanted nothing to do with long-term services and supports, and was like, and he always used to tease me that I never took a class with him. I was like, well, I don't want to work in long-term care. So, and lo and behold, that's pretty much where I've spent most of my career, is on issues related to long-term services and supports, healthcare, and now most recently, whatever, what gets a lot of attention these days in healthcare is sort of healthcare and social care integration. So I'll talk a little bit about that a little bit later on. From Scripps, I went to, what was then the American Association of Homes and Services for the Aging, now is Leading Age, and worked for Robin Stone at what then was called the Institute for the Future of Aging Services, and now has a different name because everything changes its names, including the organization that I work for right now. I worked there for about 5 years, went from there to the National Council on Aging, working on Medicare Part D and access to benefits. I'll talk a little bit more about that when I get to the next slide and talk about policy changes. And then had the opportunity to pursue a federal position at what was then, again, speaking of the name change thing, was then the Administration on Aging. It is now the Administration for Community Living. And hope for those of you who may not know, hopefully you all do, but the Administration for Community Living is one of the operating divisions within the U.S. Department of Health and Human Services. It is the smallest of the operating divisions within HHS. It is about, I think, roughly now in the neighborhood of 200 to 250 staff in the great big sea of 80, probably 80 now, closer to maybe 90,000 people around the country who work for the Department of Health and Human Services. But it was a great place to work, and I got to, start working on the stuff on kind of things I work on right now when it comes to area agencies on aging, community-based organizations, and their role in contracting with healthcare entities to provide long-term services and supports, address social determinants of health like nutrition and housing and transportation and all the kinds of services that AAAs have been providing for 50 plus years. And then I've been able to continue that work on business acumen and integrated care in my role now again at US Aging, formerly the National Association of Area Agencies on Aging. And I've been at US Aging now for about 4 years. I direct something called the Aging and Disability Business Institute, as Leah mentioned, which is basically a training and technical assistance center that is funded by the John A. Hartford Foundation, the SCAN Foundation, and the Administration for Community Living. As I mentioned, we do training and technical assistance. Our mission is to build the capacity of area agencies on aging and other aging and disability community-based organizations to partner and contract with healthcare entities. So we do that through our training and TA work. We do resource development. We have a host of resources available on our website at aginganddisabilitybusinessinstitute.org. We provide thought leadership at the national level on the value that community-based organizations, and in particular AAAs, given where we're based, bring to integrated care, and as partners in contracting organizations with healthcare entities like health plans and health systems, accountable care organizations, and a host of other kinds of healthcare providers and payers. We also we have a consulting program for larger scale projects that community-based organizations bring to us that they need help with. And we also do information gathering. We are lucky enough, I get to continue my relationship with our friends at Scripps. Scripps Gerontology Center serves as our evaluator at the Aging and Disability Business Institute and our partner on not only on all pretty much all the research work that we do within the Aging and Disability Business Institute. Most notably, we do periodic requests for information surveys to gauge the extent to which AAAs and other community-based organizations are in fact partnering and contracting with healthcare entities. We've done 4 of those surveys in partnership with Scripps over the past 5+ years. And we are also doing some really exciting qualitative research now, looking at networks of community-based organizations that are growing pretty dramatically, actually, around the country in partnership to larger scale healthcare contracting opportunities with Medicare Advantage plans and other larger scale entities that may be looking for to provide social determinants of health interventions or other kinds of services that AAAs and CBOs offer. So I've really been fortunate to work for a number of terrific organizations and have had some really great bosses over the years who have not only been inspiring to me in terms of their passion for the field, and their dedication to the organizations that we've worked with directly, as well as to more importantly, to the older adults, the people with disabilities, and the caregivers whom those organizations serve. So it's been a lot of fun, as I was preparing for this session this week, thinking back over the kinds of work that we've gotten to do and what we've witnessed in the field, and really what my time at Scripps, both as a student and then working, really prepared me for in terms of the kind of work that we get to do. So, I kind of fell into the focus that I had. Like I said, when I started working in the field, I really honestly wanted, as I mentioned before, didn't really want to have anything to do with long-term services and supports. I had spent some time my first job out of college was as a social worker in a very large nursing home, for-profit nursing home, which pretty much, cured me at that point of wanting to work in long-term services and supports. But then, I had the opportunity, as I mentioned, with Scripps to work on the Ohio Long-Term Care Research Project and kind of fell into the work that really has been my focus for pretty much the rest of my career, which has been on taking really complicated policies and policy issues and trying to work on translating them. Oops, and I jumped ahead on my slides. And translating them for the professionals who are doing the work at the grassroots level every day, and in turn, the people whom they serve. So I really have focused on providing technical assistance, taking those complicated policy issues and putting them in terms that are hopefully easy to understand, so that they can then in turn work with older adults in their communities, whether it's on providing Medicare education or on making choices with regard to what their coverage should look like, or making long-term care choices. And what started that for me was a project that I got to work on when I was at Scripps, which we decided we were going to work on, and I honestly forget how this sort of came about, but it was under the Ohio Long-Term Care Research Project. We decided we were going to work on a consumer guide to long-term care decision making, and it was a fascinating project to work on, and really kind of taking that maze that is long-term, making decisions about long-term services and supports, which often, as probably you all know, happens in a crisis for most families. And thinking about how you could break down all the complicated terms that are out there and the complicated decisions that people need to make, and put it in easy to understand terms. And it was a lot of fun, and it eventually got adopted. We got to work with lots of different people within Scripps, and it got adopted by the Ohio Department on Aging, and they used it. Periodically, I would go back even after I moved to DC and kind of look, are they still using this? They printed it, they used it as part of their resources, which was really exciting for me as a young professional at that point. And it really gave me the experience that I needed, and sort of the passion for taking those issues and turning them into usable resources, usable, digestible resources for professionals and volunteers and older adults alike. That's really been the backbone of my career over the course of the past, now almost 30 years. So, and the past 30 years have really been ripe for policy. We've had some huge shifts when it comes to policy, particularly as it relates to healthcare for older adults, and also now, most recently, the integration of healthcare and the kind of social care that AAAs and the Aging Network provide. So, where I've been and the organizations that I've worked for have really tracked a lot of these changes. So, it started with some of the long-term services and supports work that I was able to do with Scripps with that consumer guide. During that time, Medicare Part C was born, which was, Medicare, what is now known as Medicare Advantage, then was Medicare Plus Choice. I got to work on some, while I was at Leading Age, I worked on a project called the Center for Medicare Education, which was really designed to help explain Medicare Plus Choice and the choices that older adults, Medicare beneficiaries, who are older adults and persons with disabilities would have to make about whether to stay in traditional Medicare fee-for-service, or original Medicare, as it was called, and or pick a Medicare health plan, or a Medicare Part C plan, now known as Medicare Advantage. So I worked on that in terms of translating some of that and the choices that people would need to make for the professionals in the field who were working for state health insurance assistance programs or area agencies on aging, or other folks who touched and who worked with older adults on making those kinds of choices. From there, as I mentioned, I went to National Council on Aging. At the time, that was when Medicare Part D passed, and for a while we had Medicare drug cards, and then Medicare, Part D drug coverage was added to Medicare, which opened up, again, another, sort of host of choices that older adults, caregivers would have to make, and new work for AAAs, for SHIPs, for others who are working with with Medicare beneficiaries about those kinds of choices. Would they pick a Medicare drug plan and add it to their Medicare fee-for-service coverage? Would they pick a plan that covered both their healthcare and their prescription coverage? And we, at the time, working at the National Council on Aging, we were focused on helping people with limited incomes and resources to sign up for what was called the extra help. So coverage through Medicare Part D that would pay for the people's Part D premiums, cost sharing, and other cost sharing. So we were kind of focusing a lot on outreach and on enrollment assistance in the plans, helping people to sign up. We got to, we met regularly with the Social Security Administration. We're involved in sort of national level campaigns to help drive enrollment. We were part of exciting work that was happening in states on how you leverage benefits information. So at the time, a number of states had their own state-funded prescription drug coverage that people had signed up for. There was information in there about their incomes, potentially their assets, if there was an asset test. and how you could potentially, how states in particular, and also at the national level, Social Security was also looking at those kinds of issues, how you could share data and share some of that benefits information. So people didn't have to, beneficiaries and their families didn't have to provide the same information over and over again if they were, signing up for a state prescription drug program or applying for the Medicare Part D extra help, or the Medicare savings programs, which cover people's other Medicare premiums and cost sharing, for people with limited incomes and resources, potentially even SNAP, the Supplemental Nutrition Assistance Program, at the state level, sharing some of that data to make it easier for older adults, for persons with disabilities and their families to get the benefits for which they were eligible for without having to go through what are often overly complicated benefits applications. And I can say that having helped my mother-in-law apply for Medicaid many years ago, when she needed, had spent down and needed nursing facility coverage. Some of those applications are incredibly complex. I needed to ask people questions when I was filling out the application, and I work in this field and, had worked in the field for a long time at that point. So, it was really exciting to be part of those changes and to help make that process easier for older adults and their families. Next came the Affordable Care Act, which was, again, an opportunity to talk about. We thought Medicare Part D was complicated. The Affordable Care Act really, kind of left Medicare Part D in the dust in terms of the scope of the legislation, the kinds of change that was being driven by the Affordable Care Act. It really started the pathway toward that health and social care integration. Some states like Minnesota had been working on that for a long time, in terms of their kind of work with people who are dually enrolled in Medicare and Medicaid. But the rest of the country had kind of lagged behind on that. The Affordable Care Act pushed us in that direction of really thinking about how the silos that existed in terms of healthcare and long-term services and supports, and how we could bring those together to look at the holistic needs of older adults and persons with disabilities, and of course, caregivers. So with the Affordable Care Act, I had an opportunity to move to ACL to help ACL, even though at the time, then the Administration on Aging's, sort of role and opportunities within the Affordable Care Act were pretty small. There were opportunities there in terms of particularly a program called the Community-Based Care Transition Program, which was specifically designed for AAAs and aging and disability resource centers to work with hospitals to reduce hospital readmission rates under Medicare, which opened a door that led to the work that I'm doing right now. Within the past several years, as this integration or this emphasis on integration and the move toward value-based care and value-based payments, so paying healthcare organizations based on the outcomes that they're able to achieve, the quality of the services that they're able to provide, rather than the number of services that they're able to provide or the volume of services that they provide, has really helped to move us in that direction toward integration. Because most of people's health, one of our partners always says, health happens at home, right? Most of the experience people have of their health happens, in their homes and communities, and not in hospitals or clinics, et cetera, outside their sort of four walls. So there's a real need, and we believe that the system is better able to achieve improved outcomes, and achieve what was called the triple aim of, improved population health, better quality services, and if not lower costs, certainly smarter spending, and spending money where we want to within the healthcare system to keep people in their homes and communities where they overwhelmingly prefer to be. You know, that community-based organizations, and in particular area agencies on aging, play a major role in that, and need to be part of that system. And not just as unfunded referrals. When I was at ACL in the very beginning stages, I went with in very beginning stages of my work there, I happened to go with Kathy Greenlee, who was then the administrator of the assistant secretary for aging, and then the administrator of the Administration for Community Living, to meet with the head of CMS's Center for Medicare and Medicaid Innovation. And we were kind of making the pitch about the good work that AAAs do and the Aging Network. And he sort of looked at us and said, "Oh, I know who you all are. You all are those free people within the community." When I was at, the health system he used to be at, I sent people to you all the time. It's like, great, those free people within the community. So that's sort of that is what drives the work that we do at the Aging and Disability Business Institute, which, at the heart of that is that if AAAs and other community-based organizations in the field of aging and disability are helping the healthcare system to achieve better outcomes, that they need to be paid for those services, and paid, out of Medicare, out of Medicaid, for the provision of those services whenever that is possible. We recognize that Medicare's coverage of those kinds of services has historically been very limited. We've seen new opportunities with the passage of the Bipartisan Budget Act, which included the Chronic Care Act in 2018, that allowed more flexibility for Medicare Advantage plans to cover home and community-based limited home and community-based services as part of their supplemental benefits. We've seen more opportunities and more doors opening on that. Medicare still has a long way to go. Medicaid has long been working in this space, but Medicare has got a long way to go in terms of some of that. But the door has been opened. There have been opportunities. We've seen AAAs and other CBOs that are contracting with Medicare Advantage plans, although we still have a long way to go on that as well. But it's it's meant for a sea change when it comes to AAAs, how AAAs operate and how the Aging Network operates, and other community-based organizations within the field. So really the last slide that I have is talking about where we are sort of as an aging network. And it's really kind of a network at a crossroads. AAAs increase, we've been talking about this for now, 10 plus years, after the Affordable Care Act and sort of opportunities there in terms of how AAAs and the Aging Network could position themselves to move, at the heart of what we do is the Older Americans Act, the kinds of services that are provided there, nutrition and transportation and personal care and evidence-based health promotion programs. But how do we take what we've learned and move beyond? What we know from our AAA surveys that we do every few years with funding from ACL, and we do those in partnership with Scripps, is that, Older Americans Act funding, is a limited share of the, of the budget of many area agencies on aging. For some, it's most of their budget, but for many, I think nationwide, it's something like it represents about 44% of AAA budgets, as a share of AAA's budgets. So AAAs and the Aging Network are really thinking about how they move beyond that, how they think about healthcare contracting, how they think about private pay services, and what else lies ahead for them in terms of the role that they can play in achieving, healthcare and social care integration. We've increasingly been talking about, healthcare gets, they get clinicians, they get specialists, So as we've been engaging on the national level with in coalitions at, at think tanks, at tables with, sort of national level, whether it's policymakers or those in national organizations or national health plans, federal agencies who are making decisions about what these systems look like, we've been increasingly talking about the work that AAAs do as being social care experts or social care specialists, which are terms that allow us to sort of maintain the integrity of what we do in terms of being, mission driven, not having services be overly medicalized, but having them be seen more on an equal footing with the kind of services that healthcare payers and providers offer. I don't think we're there yet in terms of that equal footing, but we're definitely making some strides. But where we've seen, certainly where we have room for growth or where we need more work, and where we're seeing the impact of what the aging network has looked like, are some of the other sort of items here on the screen. Increasingly, we at US Aging and in the work that we do at the Aging and Disability Business Institute are looking at the role of structure, particularly when it comes to AAAs. Right now, between 55 and 60% of area agencies on aging are in some form of government. They are either part of city government, county government, or regional councils of government. That brings with it its own set of challenges when it comes to healthcare contracting. In terms of getting buy-in from county boards or regional councils of the sort of larger structure of the regional councils of government. It's not impossible to work around those structures, and many government-based AAAs have when it comes to healthcare contracting, but it definitely brings its own set of challenges to this work. Also looking at measurement, for many years, Older Americans Act services and AAAs and states have looked at outputs. How many meals do you provide? How many rides do you provide? How many people do you serve? As opposed to outcomes. What impact have those services had on the lives of the people being served, on older adults, on caregivers, et cetera. So, again, the network, the federal agencies that administer the Older Americans Act, are really starting to look more at that, and how we can get at some of that outcome data as AAAs and other CBOs engage in contracts, as they work with partners like quality improvement organizations, as they work with researchers. We've been able to do some really exciting work with Scripps and with Yale University and UC Berkeley, accessing utilization data and looking at the kinds of partnerships that AAAs have and contracting through our request for information surveys. In addition to sort of looking at structure and how we measure quality, infrastructure is also really important in all of this. One of the examples, we talk a lot these days with AAAs and other CBOs as part of this healthcare contracting work about, information technology and the need for that in order to be able to not only to bill healthcare providers and payers with whom or with which AAAs may have contracts, but also to be able to track outcomes, to be able to report on quality, to troubleshoot, to share referrals that may come through the healthcare sector and with their partners at the community level. While meaningful use and the High Tech Act were not without its issues, it did offer infrastructure dollars for hospitals and for physician offices in terms of, accessing and paying for the implementation of electronic health records or electronic medical records. That same level of investment has not yet been made in the social care structure or the social care sector. And that is something we increasingly keep trying to bring not only to ACL's attention, which they certainly know about, but also to CMS's, CMS's attention, and the need for that in order to make sure that we can provide the social care that is necessary to achieve better health outcomes, and so forth. And then the last thing I really wanted to talk about was, what we're seeing in terms of response from AAAs and community-based organizations, and the numbers keep increasing. We saw a little bit of a flattening between 2020 and 2021 in terms of the percentage of community-based organizations that reported during one of our surveys that they had contracts with healthcare entities. And we largely believe, that was in due to the pandemic. But where we have seen, tremendous growth, though, is in the formation of CBO networks. So groups of AAAs, other aging and disability community-based organizations coming together in a region of a state or in a state, and even in a few situations across state lines, to form networks that allow them to achieve economies of scale, to invest in infrastructure, to have shared services that allow them to more effectively contract and pursue larger scale contracting opportunities that may be available within their states. So potentially with Medicare Advantage plans, with accountable care organizations, certainly with Medicaid health plans, and more. So, and the work that we get to do at the Business Institute is really exciting. And obviously I get pretty passionate about it, in terms of really helping to help the network continue to transform itself, to be that partner, to be on that equal footing with the healthcare sector, so that we can continue to improve the structures and the systems that are out there that serve older adults, people with disabilities, and caregivers more effectively. So with that, I think I'd like to stop there, answer questions that folks may have, or engage in dialogue with you all in terms of what you see in your jobs, in terms of the kinds of things that I've been talking about. So I guess I'll turn things back over to Leah to hopefully, I don't know how you all have done Q&A on these kinds of, in these presentations, but I'll turn things back over to you.
Yeah, Marisa, thank you so much. That was a great overview, and I love hearing about your background and how you went to, different places in your career, and hearing the update on your perspective of the Aging Network. And so I want to open the floor to questions. I'm guessing Bob maybe has a question, and or I would expect maybe. But anyone else, you can feel free to put it in the chat, or if you want to raise your hand or unmute, let's open it up.
Well, sure. I'll start because you called me out, Leah. So I guess, Marisa, this is a question about, Ohio certainly is one of those states that's definitely into the duals world and long-term services. And I'm wondering what you think about the long-term effects of heavily managed care, LTSS, and what that will mean for the Aging Network.
So that's a great question. It's certainly it's been interesting to see at US Aging, because we know that a lot of AAAs, many of whom serve as state health insurance assistance programs, have a lot of, and certainly disability organizations have a lot of trepidation about the move toward managed long-term services and supports. We know what states want out of it, right? They want more predictable costs. They want better care coordination, and a host of other things. But it's certainly helpful for states in terms of driving, at least containing or attempting to contain Medicaid costs. But in terms of what it's doing to the Aging Network, and for the Aging Network, I think we've seen kind of a mixed bag of things. It certainly opened up opportunities, contracting opportunities, as we saw. We continue to see increases in the proportion of AAAs that are contracting, with managed care plans, whether those are Medicaid health plans, or Medicare Advantage plans, and even commercial plans. And Ohio's been at the forefront on some of this. Ohio's been able to do what a lot of states haven't been able to do, and certainly did in the duals demonstration, in terms of carving out a role for themselves in that program. So, Ohio AAAs and the association were able to successfully advocate for a role written in the contract for themselves in terms of assessment and I believe care coordination. A lot of other states have not been able to achieve that in terms of getting written into the contract. In fact, one of the most frequent requests that we get from our members is, can't you get CMS to say that, that states and managed care plans need to contract with us? It's like, wow, I wish we had that kind of power. We don't, unfortunately. We certainly try to make the case for it as often as we can. But we have not, CMS, at least from my experience at ACL, is always sort of loath to say, to add those kinds of requirements on their side of things. They hear it and they understand the needs, but they tend not to. They tend to like to give states more of that power and ability than they will necessarily kind of take it at CMS. So in many states, we've seen the role of AAAs change a lot, particularly in terms of care management. For a long time, AAAs had, and many AAAs in many states around the country have provided care management services under their state's Medicaid home and community-based services waivers. As states move to long-term services, manage long-term services and supports, sometimes AAAs have been able to maintain a role in care coordination or assessment, but often managed care plans want to hold on to that, right? They have a very, specific view of care management, and it is a role that they want to maintain for themselves. In many cases, they'll contract with AAAs and other CBOs for other kinds of services, but not necessarily care management. We're also, seeing AAAs having to, and states, can take an expansive role or a really restrictive role in terms of looking at how AAAs and other CBOs manage conflict of interest when it comes to their roles within managed systems. And, the final thing, just in terms of that, is that nobody's going to be able to achieve the promise. And I know you all are at the forefront of looking at this, in Ohio and elsewhere, within the long-term services and supports scorecard that you and I both sit on the advisory panel for. Nobody's going to be able to achieve this promise if we can't address the workforce issues within the direct care workforce that are happening around the country, whether it's home and community-based services or long-term care facilities. The workforce crisis is upon us. It's happening within AAAs too, in addition to with the providers with whom they work. Some of the workforce surveys that we've done of AAAs, we're seeing a lot of retirements after the pandemic, lots of people moving to other kinds of positions that may be better paid than we've traditionally been able to do within the Aging Network, and a lot of people leaving the field. So I'll just kind of throw that in there as the one of the big things that we all need to be working on and are starting to work on in a number of places in order to be able to achieve some of that promise.
All right, thank you. Marisa, I have, there's a message in the text from Suzanne. Great presentation, Marisa. Can you talk about partnerships between AAAs and public health entities and what these partnerships might mean for system transformation?
Yeah, so we, as part of our last request for information survey, one of the things that we asked about, considering it was 2021, and we were all sort of right in the heart of the pandemic, wanted to look, and also because, and admittedly, we are funded by the John A. Hartford Foundation for the much of the work that we do at the Aging and Disability Business Institute. We are part of their priority area related to age-friendly health systems. We are their, as we like to say, we are their CBO arm in terms of looking at age-friendly systems. That work includes sort of traditional health systems, and funding that the foundation does there. It includes work that they do with Trust for America's Health on creating age-friendly public health systems, and then the work that we do with area agencies on aging and other CBOs. What we found in our survey was that I think it was somewhere between 80 and 90% of the community-based organizations that responded to the survey indicated that they were working with public health in some way. And I think it was around 85% for AAAs. I don't have the figures right in front of me, but I know it was in the 80s. And we've seen more of that happening in light of the pandemic, whether it was because of vaccine support that was needed, in terms of getting people to sites to get vaccinated, or providing support that would allow vaccines to be delivered at home to people who might be homebound, a host of other things, virtual programming that could address social isolation as older adults, were sort of in lockdown as a result of the pandemic. More partnerships and more connections between these agencies is always a good thing, right? In terms of making sure that people are able to stay as healthy, older adults and caregivers are able to stay as healthy as they can be, get the vaccinations that they need, get the health access to healthcare, to physical activity, and so forth. It's why I think we're seeing more states look at becoming age-friendly states, or now kind of the latest, California being at the start, but now other states kind of picking up the ball and running with it in terms of the development of master plans for aging that look across systems in terms of what we need to do to address the needs of older adults, and caregivers and so forth, and to support people as they age throughout the lifespan. Where I think that, it gets a little more challenging in terms of the kind of work that we do at the Aging and Disability Business Institute is really in terms of how those partnerships could potentially, what the effect might be on the healthcare contracting, which is at the heart of what we do and what we try to promote between AAAs and CBOs in the healthcare sector. Sort of where public health kind of fits into that is something we're trying to wrestle with right now. Sometimes there's been a little tension. Certainly I can testify to this at the federal level when I was at ACL, there, in terms of funding, there's always kind of a tussle for funding at the federal level and at all levels, I think, at the state and at the local level. Sometimes I know we within aging feel like public health is trying to kind of encroach on the turf, I guess, that AAAs and other aging network organizations have had. Certainly but there, I believe in my optimistic moments, I think more of this partnership is good. There is plenty of work that needs to be done and plenty of room and need for cross-sector partnership, whether it's on areas related to workforce, which public health is absolutely struggling with as well, or on the promotion of health or access to benefits. there's plenty of room for work for all of us in this. So, but to be continued in terms of how those roles and partnerships kind of play out.
All right. And if anyone else has a question, let's open the floor. I also, Marisa, would love to hear any kind of advice. We've got many students on here, both in the MGS program and the PhD program. I'm just curious if you have any advice or anything for students in terms of post-graduation opportunities, and anything you might want to present for suggestions or anything like that.
Yeah, and we just got a question in chat from Catherine. Thank you, Catherine, about the Aging Network and Veterans Affairs and that relationship. I think there's been a fair amount of growth there over the past decade, and a lot of work that has happened between ACL and the VA in terms of what was originally called Veterans Directed Home and Community-Based Services, which often were partnerships and contracts between VA medical centers and AAAs and aging and disability resource centers and other organizations, in some cases centers for independent living that serve people with physical disabilities, in terms of self-directed home and community-based services for veterans that AAAs would work with veterans to be able to provide. And we've seen that continue to grow with the choice program under the VA and so forth. We've seen that it's in the top 3, I think it was, in our survey in terms of contracts that AAAs and other community-based organizations have, medical or healthcare systems with which AAAs and other CBOs may have contracts. I think in some, like a lot of these AAA or CBO healthcare contracting opportunities, there's always some sort of tussle there, and it's sort of with the VA, it's like one VA medical center at a time. Some of them may be incredibly open to these kinds of partnerships and contracts, others may not be. Same can be said of hospitals, health plans, and so forth. But I do think there's been a lot of work that's happened with ACL in states, with AAAs on that front. I think it'll continue to grow, particularly as AAAs continue to gain more contracting experience and more opportunities for that integration of health and social care keep happening. But to get at your question, Leah, about sort of advice for students, I've had the opportunity to talk to a number of different classes over the years, through Scripps and at Miami. And I guess, a couple of things. One is take advantage of the incredible network that you have of, graduates who have come before you and who are in the program, whether it's the PhD program, the master's program with you right now. I still keep in touch with graduates from my class, whether it's in the professional world or, on Facebook, etc. And, we still keep in touch and see each other at conferences. I've been, lucky enough to be able to work with Scripps over the years, and we all see each other at conferences, and have gotten the opportunity to work together. Continue to take advantage of and nurture those relationships. When you're out finding jobs, it's an incredible network to be able to work with. And I personally, for the students who are out there, welcome your contact at any time. I've had any number of students contact me over the years, or kind of connect with me on LinkedIn, etc. I love to connect good people, and especially well-trained people, which I know you are, having come through this, the program at Miami, with jobs that are out there. And I believe aging jobs are only going to continue to grow as the field continues to grow. So I am really happy for you all, particularly if you're interested in being in the DC area. Contact me, get in touch with me. happy to talk with you, to point job opportunities as they come across my desk, or across my email, more likely, your way, and so forth. So definitely, please do take advantage of that. And I welcome those opportunities for interaction and connection with you all. The other thing I would say is, particularly for those of you who are students, the first job you have is definitely not going to be the last job you have, within the field. So, while you're in a position, take advantage of whatever you can, learn as much as you can in that job, take advantage of trainings that they may offer you, of people whom they can introduce you to, and get as much as you can out of every job that you're in, because it's only going to prepare you even better for the next job. I got my first job in DC because I met Robin Stone at a conference that we put together when I was at Scripps. So there are always those relationships and those connections that your colleagues can help you to foster, that your professors can help you to foster, in the field. But you've got to want to be able to do that. And you've got to come to a job and with what you want out of it for yourself. I always ask people who come to work for me, like, you tell me what I have things that I need you to do as a member of my team, but if there are things that, if you have interests that I can help to foster, or skills that I, as your supervisor, can help you to build, I want to be able to do that. But I won't know that unless you tell me. So you've got to kind of come at jobs and internships and so forth with what you want to be able to get out of it. And also, I would add, use those to think about the kind of professional, that you want to be. I had great teachers and great examples in front of me, as do you, with the team at Scripps. And I've been lucky enough, and they spoiled me for having good bosses wherever I went, and being and knowing that the kind of people that I wanted to work for, and ultimately the kind of professional that I wanted to be. And that's what your jobs and your internships and, your schooling right now, can give you. So, but you need to be able to take advantage of it and know what you want to get out of it.
Great. Thank you. Great advice. I second that. And we are doing some networking, kind of fundamentals, some training sessions in January. So we'll be learning about how to network and some alumni to network with. So thank you, Marisa. All right. Well, it's 2 minutes before 1. Thank you so much, Marisa, for being here and helping us celebrate our 100 years.
Anytime. Thank you for the invite. It was great to see everybody, and great to be here, with you all.
Yeah. Thank you. Thanks
Marisa. See you next week in Columbus. Yeah.